So our next speaker is Dr. Christopher Silliman. Chris is a professor in the Department of Pediatrics and the Department of Surgery at the School of Medicine, University of Colorado. He is also an independent investigator at in the research labs at Blood Center in Denver and an attending pediatric hematologist oncologist at Colorado Children's Hospital. His basic research interests are varied, including inflammation, innate immunity, receptor-mediated signaling on leukocytes and the endothelium, and in transfusion medicine, has a particular interest on transfusion-related acute lung injury and resuscitation following injury. So that is what he's going to be speaking about, I think. Yes. There you go.
Thank you all for the invite, and here we go. So TRALI is the acute onset of non-cardiogenic pulmonary edema with profound hypoxemia with PaO2 FiO2 ratios less than 300 at sea level, and also presents with chest x-rays with bilateral fluffy infiltrates. TRALI is also new acute lung injury temporally related to transfusion with or without a predisposing condition for development of lung injury. And it can also be worsening of pulmonary function temporally related to transfusion. TRALI still is the most common cause of transfusion-related death worldwide. The incidence in the U.S. is higher than elsewhere, 1 in 1,000 to 1 in 5,000, with Europe being less. It has a 5 to 25% mortality, with lower rates appearing to predominate, and the attendant morbidity and mortality may be higher secondary to underreporting. Treatment of TRALI is supportive care and consists of oxygen, mechanical ventilation, and even ECMO in some cases. Look-back studies have been illustrative. Dr. Van Buren had a donor with an HLA-2B antibody. Majority of the patients, even with an antigen-antibody pairing, did not develop TRALI, and therefore she surmised that the clinical condition of the patient is important. I cite this study because people think I did the two event model. I stole it. Patty Kopko in 2002 had a donor with HNA3A antibodies, and over 95% of us have the antigen. 8 unrecognized TRALI reactions were found. However, 27 patients did not get TRALI even with a known antigen-antibody pairing. Pearl Toy had a similar experience, donor with lots of different antibodies. No patients except the one case developed TRALI. So the two-event pathogenesis, at least two events we might say, it consists of a first event, which are clinical factors that cause pulmonary sequestration of PMNs in the capillaries. And the second event is the infusion of something, a biological response modifier antibody, in the plasma or supernatant that activates the sequestered neutrophils, causing neutrophil-mediated endothelial damage and acute lung injury. What are these biological response modulators, how they work? And I'm not going to go through all of them. I will focus on the things that I have not been able to get published. So is TRALI also really neutrophil-mediated? So I think it is, so I want to review for you for a sec here innate immunity in the lung and in the tissues or lung proper. An infection can form, and signals are sent out to the endothelium. And as your PMNs are squeezing along your capillaries, they encounter activated endothelium and are slowed or tethered or even captured by some biologists by the selectins. This slows them, and as they get nearer to the nidus of infection, chemokines are released which prime the PMNs, changing them from non-adherent to adherent. They attach through ICAM1 in the lung and the beta-2 integrins. They can then diapodese through, chemotax 2, and engulf the invaders and destroy them. In lung injury, it's not quite the same because there's nothing in the extravascular or organ itself. So the capillaries become activated, the PMNs become captured by lectins. They become primed by endothelial activation from chemokines. They attach with their beta-2 integrins and ICAM1, and they're all dressed up, set to do what they do with nowhere to go. And they're hyper-reactive because they're adherent. A transfusion may occur, activate the oxidase or non-oxidative parts of the microbicidal arsenal, causing endothelial damage, capillary leak, edema, and ALI. First events I'll just mention briefly. In a study I did with Lynn Boschkoff years ago from Alberta, we found two groups, patients with hematologic malignancies undergoing induction chemotherapy with absolute neutrophil counts greater than 500, and cardiac disease requiring bypass. I need to mention the FDA found this second group of patients as the most common patient predisposition in their review of fatal TRALI as well. The proposed risk factors, I will name a few. Recent surgery within 24 hours, and the seminal work done by Mark Popovsky in 1985. All 36 patients that had surgery within 24 hours, most of them the day of. Acute active infection, massive transfusion, and HUS-TTP, which are syndromes of endothelial activation. TRALI in the critically ill, I want to mention because it's probably the highest incidence of this adverse event is in the critical ill as done in the Mayo. It's up to 8%. We did some work at CU with GI bleeders admitted to the MICU. 16.7% developed acute lung injury and met the clinical definition following plasma infusion. And 29% of patients with end-stage liver disease developed ALI post-transfusion. This was supposed to be a negative study. So we believe that TRALI is common in this patient population. So I want to get into second events. The one I want to talk about is antibodies directed against HLA class II antibodies. And when you look at the articles written about this entity, these are the things you must have. You must have infusion of donor antibodies directed against specific host HLA class II antigens. This results in monocyte activation resulting in synthesis and release of pro-inflammatory cytokines, chemokines, and lipids. And you must have activation of the pulmonary endothelium. Last but not least, you must have neutrophils and neutrophil-mediated acute lung injury. To review then the isolated perfused rat lung model done by the Germans that cemented this pathophysiology, they had their rats treated with endotoxin or saline as the control, and the lungs were isolated, ventilated, and perfused. In other words, there's no liver to detoxify, there's no kidney to excrete, so you just keep going through the cycle in the lung. I used to do these experiments. I'm just as guilty as everybody else is. Okay, lungs exhibited acute lung injury from rats treated with endotoxin first and perfused with either the supernatant from monocytes incubated with cognate antibodies in culture and human neutrophils. Or they could infuse the monocytes themselves, the antibodies to the class II antigens and human neutrophils. If you take any of these away, no injury was seen. So questions arise, at least to me, maybe I'm the only one. How many monocytes do you need and how long do you need to incubate? Supernatant from monocyte in vitro cultures is likely superphysiologic of the released mediators. And they looked at the chemokines, IL-8, GRO-alpha, and ENA-78, and leukotriene B4. Synthesis and release as published by others in vitro models of TRALI, it took 4 hours to get enough of these things synthesized. But in vivo, you expect it to be much quicker. The mean monocyte counts in healthy adults are somewhere around 300 per ml. Is this sufficient? And last but not least, do the new rules for neutrophils and antigen presentation, as first shown in 1998, play a role in TRALI? So do PMNs express HLA class II antigens? Well, classical teaching says no. However, if you give PMNs or patients in vivo or in vitro GM-CSF, gamma interferon, and TNF, they do express these antigens. Chronic inflammatory diseases and collagen vascular diseases cause an increased surface expression of HLA class II on neutrophils. Bacterial infections and exposure in vitro, whether it be gram-positive or gram-negative, you get class II antigens on the neutrophil surface. Engagement of the beta-2 integrins, simple adherence will also cause this. And last but not least, these MHC class II antigens on neutrophils are active because if you ligate them, they make a lot of IL-8 and release it. So we hypothesize that TRALI occurs via two events. Yeah, right. First event induces the surface expression of MHC class II antigens on the neutrophil membrane and pro-inflammatory activation of the pulmonary vascular endothelium. The second event is in the transfusion of donor antibodies to these MHC class II antigens, which results in neutrophil activation and acute lung injury. So we used OX6 as a class II MHC antigen on rats. All the rat work was done at Oxford, hence OX. Unsuspecting rats were then given a first event, saline controls, endotoxin or IP-MCSF, interferon gamma for 24 hours, followed by tumor necrosis factor alpha for 2 hours. We then would isolate PMNs, look at OX6 by flow, incubate with the antibodies, and see if we could prime the FMLF-induced respiratory burst. Here are some of these data. Figure 1 just shows a flow diagram with the isotype in the lightest gray, the control, and then you see a shift to the right with both endotoxin and the cytokine cocktail. When we quantified the control MFI, shown on the y-axis, had a level that was not very high, and then with the cytokine cocktail we increased it almost fourfold, and with the endotoxin threefold. So we then wanted to see if the OX6 antibody would prime. Superoxide anion on the y-axis as a function of treatment group. These are rats treated with saline and given FMLF or FMLP, which is a bacterial tripeptide that causes oxidase activation. And you can see regardless of what group, control rats, LPS treated rats, or the cytokine cocktail, you got baseline superoxide anion production. We then give them a positive control platelet activating factor. We were able to augment that respiratory burst in all three groups. We then looked at OX6. OX6 priming did not do anything to the FMLP induced respiratory burst. However, in both the LPS and cytokine treated animals it did. And we used an FC blockade. The animal still had the priming activity shown. It was likely specific. We then went to an animal model of this, and again, rats were given a first event of LPS or the MCSF interferon for 24 hours, and I don't show you that part, but we then gave them TNF for 2 hours. The rats then received MHC class II antibodies followed by Evans blue dye, which binds albumin, incubated for 6 hours. At the end of that period, we drew plasma and did a BAL to ascertain Evans blue dye leak, which is the most sensitive way to look at lung injury. And the first event I wanted to show first that showed that we do get neutrophil sequestration. We use MPO as a marker of neutrophils. And in the saline treated animals, we had a very low level. Then when we gave the animals just LPS and sacrifice them per gram of lung tissue, we got an increase in MPO. And then with the cytokine cocktail, we got the same thing. And then these are the lung injury data. The lung injury on the y-axis is a function of treatment group. First event is saline, followed by saline. That's the background. We then use saline with mouse IgG control, and the OX6, we didn't get any injury. Next, we gave rats endotoxin, followed it by mouse IgG, no injury. However, when we gave OX6, we got significant lung leak or lung injury. Same for the interferon cocktail. We gave it, followed by saline, no injury. Gave it to rats, followed by mouse IgG, no injury. But when we gave them the OX6 antibody, we did. If we took the PMNs out the day before, we took away all the injury. So where is the antibody? And these are a bit hard to read. The DAPI stain is the blue stain, which is nuclear. WGA is the cellular membrane in gray, and the red is OX6. These are animals treated with LPS. You can see discrete areas of OX6, same with the cytokines. And then when you add neutrophils in and a antibody to them that's fluorescently linked, we got a white color when you got WGA, OX6, and the neutrophil stain all together. And as you can see, the OX6 appears to localize to the neutrophil membrane. So to conclude this part of the talk, if the first event elicits expression of MHC class II antigens, the antibodies bind to the PMN, prime the PMNs, and cause acute lung injuries, the second event in a two-event in vivo model. These data provide a direct neutrophil intrinsic pathogenesis for clinical TRALI. I'm now going to talk a little bit about mitigation. To overview it for a second, obviously if you decrease transfusions, you will decrease TRALI. One center in the U.S. has used pre-storage leukoreduction to decrease TRALI to their red cell units, but these results have not been confirmed. Antibody-negative plasma transfusion regimens have decreased fatal TRALI reactions to plasma. Strategies for platelet concentrates are pending, including measurement of donor antibodies to HLA antigens. Washing of cellular components takes everything out, lipids, soluble CD40 ligand, and antibodies from cellular components. And I want to talk a little bit about antibody removal. So when we talk about male-only plasma, the shot data, I'm sure you all know, the total number of TRALI cases in the light gray bars versus the fatal TRALI cases in 2004. They went to male only, and you can see the decrease in the number of fatal TRALI reactions. The American Red Cross demonstrated similar decreases in fatal TRALI to plasma transfusion, with possible decreases in total TRALI reactions. There were still, though, a number of reactions from platelet concentrates and had little to no effect on RBC-implicated TRALI, which makes up about 20% of it. The Mayo Clinic and UCSF, in their elimination of high-risk plasma donors, showed a significant decrease, but TRALI still happened. So just to say a few words about platelet concentrates, and some of you all know much more than I do about it. Testing of all platelet donors for antibodies to HL antigens and male-only transfusion protocols may become reality. At Bonfils, we don't do that. We use never pregnant females and males, and leave it at that. The use of additive solutions to remove most of the plasma and lessen the risk of these products has also been proposed. However, a number of reactions still occur. So just to look at what washing does, this is a packed red cell unit. Again, superoxide anion on the y-axis is a function of treatment group. This is the neutrophils with buffer. This is the neutrophils with the RBC supernatant day 42. The same unit was washed once, twice, thrice, and took away all of the activity. So antibody removal. This is an article we published a year and a half ago in Blood, and We based this experimental filter or filters on the Humanetics BP4. It was not owned by them at that time. It just resulted in a larger filter and took away about 2 to 3 mLs more of liquid. It removes 3.5 logs of leukocytes and 2 logs of platelets, but it also removes greater than 99% of all IgG, greater than 96% of HLA class 1 antibodies from positive donors, greater than 99% of HLA class 2 antibodies from positive donors, and greater than 80% of soluble CD40 ligand because it takes out your platelets. We then hypothesized that filtration of plasma with antibodies to leukocyte antigens will decrease antibody-mediated neutrophil priming and TRALI in a 2-event in vivo model. And so this is the priming story. We drew whole blood from healthy donors that we knew had the cognate antigen to what our antibodies in the plasma were against. We have some 20,000 HLA-type donors at the center where I work, so it's easy to get these. So we drew them, we isolated their PMNs, we incubated with the antibody, spiked plasma with or without filtration, we activated with FMLP and looked at the priming activity. And here are some of these results. These are cells from HLA-2 homozygotes. We gave them plasma that did not have the antibody in it, and we got a baseline of oxidase activity on the y-axis. We then gave them the HLA-2 antibodies, and we primed it, and if we filtered the plasma before we gave it, we took the priming away. For HNA3A or the old 5B antibody, same set of experiments. We took HNA3A positive PMNs, gave them plasma that did not have the antibody. We got a baseline of activity. We gave them HNA3A positive. We got priming, and if we filtered it ahead of time, it took it away. So then we did a larger study of 44 units, experimental filtration. We drew donor RBCs. We filtered them with the experimental filters B, P, and M with the BPF4 standard leukoreduction filter as the control. We sampled through storage. We then isolated the supernate and looked at priming assay and in vivo TRALI. And this is what we found. This is the lipid priming, once again on the y-axis, oxidase activity. I think if you look at the day 0 for the BPM, and this is pre-filtration, and the BPF4 filter groups, there's no difference in oxidase activity. However, at the end of storage at day 42, there's only a slight increase. It was barely statistically significant from the experimental filtration, while the standard leukoreduction filter by day 21 had significant priming activity that was augmented by day 42. Well, these results seem to be curious to us because why would you not have lipids, which we know accumulate during this storage period, still be there? Well, 2 of the enzymes required are FLAP, or 5-lipoxygenase activating protein, and 5-LO, which is 5-lipoxygenase. They have a significant amount of homology to IgG. And I think if you look, the pre versus the post, we took out FLAP. Now it does reaccumulate somewhat by day 42, but the filtration removes it. When we look then at 5-LO, which is required for the heat formation as we publish, you see before or with the BPF4, you have a good bit of 5-LO, and afterwards it goes away in 2 of the units tested. So then we went back to our in vivo TRALI model, saline controls versus endotoxin treated rats. And these are these data, lung leak on the y-axis. And if you look at animals given saline first, followed by plasma with a spiked antibody, and the filtered plasma and filtered spiked antibody plasma, there's no injury. When we then treated the rats with endotoxin, gave them plasma, and these are all heat treated, no injury, but we spiked it with the OX27 antibody, they did get injury, and if we filtered it, the injury went away. And then we looked at the supernatants because we had published previously that the supernates from day 42 can cause injury. We looked at saline, day 0, Day 42 from all groups, no injury. Endotoxin treated, day 0, no injury. However, at day 42 of the BPF4, we did get injury, and experimental filtration took it away. Antibody testing, pre-filtration, we had an HNA3A positive donor. We sent it to Brian Curtis at Wisconsin. He found it, and by Luminex bead assay, we had an HLA2 positive plasma that had all these other antibodies in it. We then filtered and sent it to the same folks, and they couldn't find anything. So to conclude, experimental filtration removes antibodies, lipids, and soluble CD40 ligand. Due to homology, 10 to 15% with IgG, filtration removes the FLAP and 5-LO enzymes responsible for some of the lipid accumulation and results in less lipid priming activity, and abrogates neutrophil priming to lipids except on the last day, and neutrophil mediated TRALI to antibodies or lipids. As far as taking capital from different companies rather than throw it up on a slide and show you what a corporate prostitute I guess I am, I take capital from New Health Sciences, Cirrus, Paul, Haemonetics, and Terumo. But I have NDAs with all of them. I don't talk to each other. I'd like to just thank Marguerite Keller, Nate McLaughlin, Samina Khan, and Tim Burke, Sam Coker, who moved from Paul to Haemonetics, Michelle Loy, and the surgeons I work with, and funding from the NBF, NHLBI, NIGMS, and now the Department of Defense. Thank you.
Yeah, hi Chris. A question about the filtration. Obviously very encouraging results, so really two questions. I didn't understand the difference between your B, P, and M filters, so I guess you had 3 different filters?
We did.
Right.
And you would have to ask the proprietary guys at Haemonetics. One was an orange huck, it was about this big, and also filtered prions. That's all I know. The second one didn't, and the third one was a different shape.
Okay.
So I don't know either.
Okay, but all 3 of these seem to work in your model system. So the obvious question is, if in fact we could abrogate, mitigate TRALI, a red cell mediated TRALI, is there any attempt at commercializing these filters and bringing forward that technology? Because I've heard nothing since your paper was published a couple of years ago.
Right, and that proprietary knowledge was sold to Haemonetics, and they had a little trouble with AS7 or Solex and maybe getting out of all of these things. So Sam is there. He developed, he's the engineer who did everything, and I don't know what will happen.
I don't know what's happening.
Sorry.
Thanks. Yeah.
So neutrophil extracellular traps are involved in a lot of the pathological processes. Do you see them in this, and do they play a role?
We do when we do histology, but you have to realize for the neutrophils to even see the lung, you have to take away the glycocalyx. And that's why your first event has to be important. Endotoxin will do it. The cytokine storm, especially tumor necrosis factor alpha, will do it as well. So, and it happens in trauma, and those patients who have heparan sulfates and syndican-1 circulating are prone to injury. And there's also an article that came out of Eric Schmidt's lab that showed that those patients that have those things circulating may be predisposed to TRALI as well, and there's an NBF grant given for that. So you have that, and then you have the other. On the histology, at the time this was done, we didn't look much for extracellular traps. We have since then, and they are there.
And so kind of related to that, a lot of the pathological processes you're describing resemble like the small vessel vasculitides. like ANCA vasculitis. Do these patients ever are they predisposed to the development of something more systemic like that?
Some are and some aren't. But again, a majority of the guys in the MICU were people with GI bleeds, and a lot of the ones that Mark Popovsky described were just right after surgery. So I don't know. There are some that are and some that aren't. It's heterogeneous.
Now, I was going to ask a similar question, Chris, in terms of involvement of the brain or other. How about the cases that are less complex in terms of not intensive care unit patients? Now, is there kidney involvement? Is there brain involvement? Has anybody looked?
They haven't a lot. I mean, everyone thought it was just the antibody bound to the antigen, and there you have it. I can't talk about what's happened before. Since then, we found the individuals who are sick and in the ICU are the ones who are prone to having it. But again, a lot of the work to take the multiparous donors out of the plasma pool has worked. The other thing that should work is if you pool plasma and you decrease the amount of antibody that you give. And there are certainly ways to do that. You can solve a detergent, treat it, you could freeze dry it, you could do lots of different things. And I'll stop with that.
Any questions? No, thank you very much.